Hi everyone, welcome back to Next Level Ophthalmology. We shall now proceed to non-infectious types of uveitis. So today we'll be discussing sarcoid Behcet's, Wood Carnage Harada syndrome, sympathetic ophthalmia, and white dot syndromes. Let's begin with sarcoidosis. It is a multi-system chronic granulomatous disease of unknown origin, and it is the most common non-infectious systemic association of uveitis. So sarcoid can affect the eye and cause anterior, intermediate, posterior, and panuveitis. So it can cause any type of uveitis. So systemically, it can present with respiratory symptoms like shortness of breath and dry cough. They are usually associated with restrictive lung disease. In the skin, they can present with erythema nodosum and lupus pernio, and the neurosarcoid variety can have meningitis and cranial nerve palsies. So, what are the ocular manifestations in sarcoid? Usually, they present with a granulomatous uveitis. Uh, Nowhere else, you never get a non-granulomatous variety of uveitis in sarcoid. It's always granulomatous. And typically, you get the mutton fat cavities, but something that is very characteristic of sarcoid is nodules which are present in the trabecular measure, and these are known as Berlin's nodules. So, what is the importance of this? When there are many a time you may get confused between TB and sarcoid. Okay, presence of these nodules pushes you more towards sarcoid. Okay, one. Second, when these nodules regress, they cause adhesions between the peripheral cornea and the iris, causing peripheral anterior synechiae. Okay, so these are adhesions between the extreme periphery of the cornea and the iris. So these are usually larger than usual and thus they cause tented synechiae. So there are synechiae within the angle. So that gives you an importance of doing performing a gonioscopy to rule out Berlin's nodules and synechiae. So it may also present as intermediate uveitis. So it can have a lot of snowball opacities and vitreous opacity. There are no particular signs in intermediate uveitis that may hint towards sarcoid. So sarcoid has to be ruled out in such patients by doing relevant blood tests and other imaging modalities. And the posterior uveitis, you might get chorioretinal granulomas, which are very small as compared to TB granulomas, which tend to be big and solitary. Here you tend to get multiple small chorioretinal granulomas, which later form atrophic lesions. So another important point here is you get retinal vasculitis, which is more commonly seen in veins. So there is periphlebitis, and veins are typically involved and they spare the arteries. So these are also classically described as candle wax drippings because they appear as thickened, the vasculitis appears as it's the candle wax dripping. So it may not be even, it might be thick on some edges and thin on other edges. So you can get an optic disc infiltration by the granuloma. Thus, you can get a swollen optic disc. Other ocular manifestations are lacrimal gland infiltration causing dry eye. So this gives you an importance of performing a Schirmer's test while ruling out sarcoidosis. Okay, you might get orbital and scleral lesions very rarely, eyelid nodules and conjunctival nodules extremely rare. So these are the ocular manifestations of sarcoid. So what are the investigations? Serum calcium and ACE levels. Yes, this is what we have been classically taught. But biopsy from the lymph nodes or any tissue for that matter is the gold standard to establish a diagnosis of sarcoid. Okay. You may want to do a chest CT scan to rule out highlight lymphadenopathy. Negative tuberculin test. This is also important. It is known as cutaneous energy, which is classically seen in sarcoidosis. There is negative tuberculin test, and if you get a bronchoalveolar lavage fluid, you can do a CD4 to CD8 count ratio. Okay, so what is the treatment in anterior uveitis? Again, you treat it with topical steroids and cycloplegics. Whenever there's posterior uveitis, you need very uh, significant dose of systemic steroids along with immunosuppressants to prevent recurrences. So this is a picture of periphlebitis in the peripheral vessel here. Can you see? So this is a typical sarcoid retinal vasculitis that you see around a vein. Okay. Moving on to Behcet's disease. Behcet's disease is an autoimmune condition. Okay, characterized by vasculitis of vessels of all sizes. So, what is the clinical triad? You get oral ulcers, genital ulcers, and uveitis. So, this history of eliciting oral and genital ulcers is extremely important in recognizing Behcet's disease. So, it's usually associated with HLA-B51, which can also be a test to establish the diagnosis of Behcet's disease. So ocular manifestations, usually the anterior uveitis tends to be bilateral, recurrent anterior uveitis with hypopyon with minimum symptoms. So that is why we refer this to as white eye hypopyon. Okay, and the hypopyon also shifts with a change in position of the head. It can even present with posterior uveitis and panuveitis. So here you can see vasculitis of both arteries and veins. In sarcoid, you saw only that the veins were involved. Okay. In end-stage disease, it tends to be very severe inflammation, so you might get phthisis very easily in such patients if not treated properly. Investigations, HLA-B51 positive pathology test, which is a skin test, which is elicited by using a sterile needle and injecting distilled water. Inflammatory markers like raised ESR and CIP. There are not many tests that help you, but pathology test is a very important test in diagnosing Behcet's in presence of all the other oral genital ulcers and the typical appearance of uveitis. So treatment again, it's on the similar lines. Posterior uveitis requires systemic steroids, immunosuppressants like azathioprine, infliximab, and interferon alpha. So this is a picture of white eye uveitis. The hypopyon usually tends to be very mobile and not as thick that we come across in HLA-B27, which is fibrinoid. So here you can see the vasculitis affecting all vessels. Let's take a question here. A 41-year-old lady presents with bilateral blurred vision of 2 weeks duration. On examination, there are large iris nodules and multiple posterior synechiae. So we are dealing with a chronic uveitis because we are not talking about cells and flare and redness here. Fundus examination is normal. On further examination, she was found to have dry cough and X-ray revealed hilar lymphadenopathy. So all of the following help in differentiating TB from sarcoid as an association for uveitis in this patient. So we are dealing with a chronic granulomatous bilateral uveitis for which TB versus sarcoid is always a differential. So what are the things that help you differentiate between the two? And the question here is which does not. So we are looking for an except here. Tuberculin test, yes, it helps because in TB, it's usually positive. In sarcoid, it's negative because of cutaneous energy. Biopsy of lymph nodes helps in uh, differentiating the two. So again, these two both are wrong answers. Granulomatous uveitis, it does not help because TB and sarcoid both cause granulomatous uveitis. Serum ACE level, certainly it is elevated in sarcoid, whereas it is not elevated in TB. The right answer here is C, because granulomatous uveitis presents in both TB and sarcoidosis. Hereford syndrome is characterized by all of the following, along with bilateral granulomatous panuveitis. So let us know what is Hereford syndrome. It is also known as uveitis fever. So what are the components of this? There is panuveitis, severe bilateral panuveitis with parotid enlargement. There is fever, malaise, and body ache. Along with that, you might even get cranial nerve palsies. Okay, so there is parotid enlargement, there is cranial nerve palsy, there is fever. So severe cough is not a requirement for Hereford syndrome. might be present as a part of sarcoid. So the right answer here is C. Match the following specific features of uveitis with their respective etiologies. So there are certain pathognomonic appearances which help in identifying certain types of uveitis, which I want you to understand and memorize. So sarcoidosis, we always use these words: candle wax drippings. Behcet syndrome, we use the term white eye hypopyon. So we have A is 3 and B is 4. And with Karanagiharada syndrome, we have something known as the sunset glow fundus, which is a deep pigmented fundus which is seen in long-standing uveitis. And sympathetic ophthalmia, we get some small granulomata at the level of choroid, which are referred to as tailin flakes nodules. So D is 1. So the right answer here is B. Okay, let's move on to an important cause of bilateral non-infectious uveitis, that is VKH syndrome. One might wonder that it is a syndrome or a disease of the Japanese or the Europe or the Middle East and all that, but it is certainly very common in India, and we see patients with VKH very frequently in our clinics as well. Okay, maybe it was discovered in the West or in the Scandinavian and the Mediterranean countries, but certainly we see a lot of VKH in India. So it is an idiopathic multi-system disorder. We don't know what the cause really is, and it's associated with HLA-DR4 and DW15. So please note that the same HLO also predisposes a person to sympathetic ophthalmia. Okay. So it has ocular, it has cutaneous and CNS manifestations. So usually leakage progresses in a particular format. Need not always be true. Okay, there is usually a prodrome phase with flu-like symptoms where there is fever, severe headache. These patients really have bad headache. I've seen these patients complain of headache more than visual symptoms. Their visual will be very low, but they will complain about the headache. It's that severe. Okay. Then there is a uveitic phase that follows, which is characterized by anterior, usually bilateral granulomatous anterior uveitis, and the posterior uveitis is characterized by multifocal chorioretinal lesions with bilateral exudative retinal detachment. So there is always an accompanying disc edema, bilateral disc edema with lot of uh, small areas of exudative retinal detachment, okay, which overlies the chorioretinitis lesions. So with time, this might come down with time, and there is depigmentation of the RP, which is referred to as the sunset glow fundus, which gives an indication that the disease is still in chronicity, but it is active. Okay, then there's depigmentation of the limbus, which is known as the Seguara sign. At the same time, you might even develop a poliosis. And then the cutaneous phase follows, which is characterized by alopecia, vitiligo, and poliosis. So, the systemic associations, you might get meningismus, encephalopathy, tinnitus, vertigo, and deafness rarely. Dermatological, we discussed poliosis and vitiligo, and in auditory symptoms, you might get tinnitus and vertigo. So the treatment is you hit the disease hard with high dose systemic steroids. Usually we start with intravenous methylprednisolone for the first 5 days to 1 week, followed by 1 mg per kg of prednisolone for prolonged periods of time, along with immunosuppressives, because these immunosuppressives take time to start and steroids are the best immunosuppressives. We start with steroids and immunosuppressives like azathioprine or methotrexate. And later we taper the steroids, keeping the immunosuppressives on for at least 2 to 3 years. So this is how a typical fundus of VKH looks. So there is disc edema. You see all these striations here. These are all caused by the several macular detachments. These are the detachments that are causing the. These are multiple detachments in the retina. The paler areas are the detached areas. Okay. So here you can see that there is pinpoint leakages that is seen in fluorescein angiogram, and the OCT shows a detached retina in the macula. Let's move on to sympathetic ophthalmia. It is a rare, serious Chronic granulomatous panuveitis. Okay, each word is important in defining sympathetic ophthalmia. It is a rare, it's not a very common disease. If you see one in a lifetime, unlucky. Serious chronic granulomatous panuveitis due to sensitization to choroidal antigen, either due to injury or surgery in the fellow eye. So, which surgery? It's usually a vitreoretinal surgery because it happens in the ciliary zone. So, there is injury, again a penetrating trauma is important. So it happens in the normal eye, that is why it is a difficult situation, because one eye we have already lost to trauma. So wounds involving the ciliary body or its incarceration have a higher chance of developing sympathetic ophthalmia. It never follows suppurative inflammation, that the pus that forms if a patient develops endophthalmitis or panophthalmitis. There is no chance that he'll develop sympathetic ophthalmia in the other eye. So, what is the time? It can happen any days between 9 days to 10 years, any time. But the given normal expected time is 6 to 12 weeks. Okay. Its incidence has come down drastically due to meticulous repair of tissues and use of potent steroids. So, what are the predisposing factors? Injury has to be a penetrating. Blunt injury does not cause sympathetic ophthalmia. It has to be in the ciliary region. The incarcerated ciliary body or lens capsular iris is a common predisposing factor. More commonly seen in pediatric, it doesn't mean that adults cannot have. So this is a pathophysiology. So this is the inciting eye. Suppose the left eye had an injury, a penetrating eye injury. Okay, so the choroidal, the uveal antigens are exposed, which cause proliferation of the helper T cells. So these helper T cells form antibodies which go and attack the choroidal antigens of the normal eye. So this can happen over any amount of period of time, and this eye is called the inciting eye, and the normal eye which develops sympathetic ophthalmia is called the sympathizing eye. So there is a prodromal stage when the sympathetic ophthalmia is just about to begin. There is ciliary congestion. The eye which was quiet till now starts to become red, and there is tenderness. Okay, sorry. And there is lacrimation in the shrunken eye. In the sympathizing eye, you might start to get photophobia, defective near vision because of the weakness of the ciliary muscle, which you cannot miss. So at this point, if you carefully observe, you might find some very few signs of anterior uveitis, ciliary tenderness, keratic precipitates. Okay, when the stage becomes established, when the disease is established, you get full-fledged granulomatous uveitis. You see a lot of APs, you might see corneal edema, you might see posterior synechiae, peripheral retinal exudation, and the Dylan Fuchs nodules. So these are always described in association with sympathetic ophthalmia and papillitis. So it tends to be chronic and may last for many months. So the treatment is hit it hard with a high dose of steroid, usually 1 gram IVMP, followed by oral prednisolone for many days. Okay, as the eye quietens down, you maintain a maintenance dose for many months and you keep monitoring the eye. Okay, at this stage, if you enucleate the blind eye, there is no point. That was a belief that was there previously. Okay, so if there are a few questions that arise here. If you enucleate the eye which has no visual potential, just so that it won't cause sympathetic ophthalmia and the other, that doesn't happen. So already the choroidal antigen has been exposed to the immunity. So there is no point in enucleating this eye. Okay, so even after the inflammation begins, again if you enucleate the exciting eye, there is no use. So only treatment is give immunosuppressives and steroids. The systemic condition that involves ocular, neurological, and dermatological manifestations and presence with bilateral granulomatous panuveitis is. So the answer is very simple. It's root Koyanagi-Harada disease. So okay, a 50-year-old one-eyed lady. Sympathetic ophthalmia is quite a favorite topic among examiners. Even though not very common, there are many terms and many pathophysiology that has to be learned through this disease. So it is quite a common question. I want you to pay attention to this disease. A 50-year-old one-eyed lady presents with pain and redness in the right eye since a week. A previous history reveals trauma, penetrating trauma to the left eye, followed by which the eye shrunk in size and she has lost vision nearly 10 years back. On examination, the following image is seen. So what do you see here? You see some big granulomatous keratic precipitate, some amount of corneal edema. And here you see some yellowish white lesions in the peripheral fundus. So these are nothing but Dehlen-Fuchs nodules and we are dealing with sympathetic ophthalmia. Okay. So what is the true statement in this condition? Topical steroids and cycloplegics will suffice. No, we require systemic steroids. HLA typing will help you differentiate from Behcet syndrome. Why do you want to differentiate it? It's a very clear-cut case of sympathetic ophthalmia. Immediate treatment with systemic steroids must be started. This is the true statement. Enucleation of the thysical eye is sufficient. Again, wrong. So the right answer here is early initiation of systemic steroids. So let's move on to the last topic of the day, white dot syndromes. These are extremely rare and for undergraduate level it's not very important. I'll just run through the names because so that you are familiar with at least the names. You should not be like, I've not heard about these names. So birdshot chorioretinopathy, usually seen more in females. All this white dot syndrome tend to be more in women. So more in women, third to sixth decade, usually bilaterally symmetrical, associated with HLA-A29. So you might have to remember a few HLA diseases when you are dealing with uveitis. I think we have already covered that in the first class. So what do you see on fundus? Flat, creamy, yellow-white spots scattered around the optic disc and along the choroidal blood vessels. So the treatment here is corticosteroids. APM-PPE, some people even call it as AMP, acute posterior multifocal placoid epitheliopathy, usually seen more in both the sexes, tends to be bilateral. They may be an antecedent headache or meningismus. And on examination again, you'll see small, very small, tiny, flat, creamy, yellow-white spots in the posterior pole, lesions which become hypopigmented when they resolve. It's usually self-limiting condition and you don't need to treat them. Serpiginous choroiditis or helicoid peripapillary chorioretinal degeneration. So this name might irritate you and you think what is happening. If you see the name, it's easy to write your answer. It is helicoid, so it is going like this. Okay, it's like a helix. Peripapillary, so it's starting from the disc. Chorioretinal degeneration. So you know that something begins and then proceeds forward. Something at the back is degenerating. So this is just like a snake is proceeding. So this is called as serpiginous choroiditis. It is a disorder of unknown origin, more commonly seen in men. Okay, so HLA-B7 is an association, and you see serpiginous areas that begin in the peripapillary area with new lesions appearing at the edge of the lesion, and the lesions proceed centripetally. Okay, they tend to be recurrent. You need to give systemic corticosteroids in these patients. Next is MUTES or multiple evanescent white dot syndrome. It's again can write your answer based on the name of the disease. So there are multiple lesions. Evanescent, it comes and goes. It's a self-limited condition. So it's an acute, painless condition and presence with visual loss. There are multiple white dots at the posterior pole with granular appearance of the macula. So this is something you want to remember. The macula has a typical granular appearance that is very characteristic of mutes, and it is a unilateral condition, one of the rarest of the white dot syndromes that is unilateral. Next is azure. Azure is acute zonal occult outer retinopathy. Again, we go by the name. Okay, it's supposed to follow a viral infection. The onset is acute. It involves zones. Some people even call it trizonal azure because there are three zones in the retina. So whatever zone is involved, there is arteriolar narrowing and depigmentation of the RPE. Sometimes it might be pigment spicules simulating retinitis pigmentosa. So many a time the sector RP that we used to diagnose previously, now people are thinking it might be azure. So it is a novel disease, more commonly seen in women, and it tends to be bilateral, and there is no treatment because we do not know what helps in azure. Okay, so they might present with photopsias, they might present with loss of vision, with progression of the chorioretinal damage. Okay, so this is about non-infectious uveitis. So the next class will be about endophthalmitis and panophthalmitis. See you around then.